Welcome back to another section of dentistry and more. Today we are going to discuss the previous year question paper that has comes under the topics obturation of root canals, endodontic emergencies, procedure accidents, surgical endodontics, and last one is endodontic periodontal relationship. Now we are moving to the first topic, that is obturation of root canal, and the long essays, it is a repeated question. Various root canal obturation technique and explain about thermoplastic obturation technique and explain in detail about the lateral condensation technique. And the short essays includes classify root canal sealers and mention the resin based sealers, define obturation, describe lateral compaction technique. And the short notes includes Gutta-percha, ideal requirements of root canal sealers, and add a note on calcium hydroxide sealer, mix pad and compactor, monoblock concept in endodontics, and last one is vertical compaction technique of obturation. First one is definition, that is according to American Association of Endodontics, this obturation is the method used to fill and seal a cleaned and shaped root canal using a root canal sealer and core filling material. And the major techniques of obturation, that is Gutta-percha obturation techniques, includes cold lateral condensation, warm vertical condensation, continuous wave compaction theory, mixed-pad and thermomechanical compaction, thermoplasticized Gutta-percha injection, carrier-based Gutta-percha, that includes thermofill, thermoplasticized, simplifill sectional obturation, and chemically plasticized Gutta-percha, and last one is custom cone. So this includes the techniques. Now we are moving to Gutta-percha. So the composition of the Gutta-percha that includes both organic content and also inorganic content, and the organic content includes Gutta-percha and waxes, that is matrix, Gutta-percha about 20% and waxes or resins, that is about 3%, and the inorganic contents includes zinc oxide plus metal sulfates, that is total 77%, and zinc oxide, that is a filler, 66%, and metal sulfates, that is heavy metal, that is 11%. And the types of Gutta-percha includes alpha form and also beta form. And this alpha form, it is brittle at room temperature, whereas the beta form, it is flexible at room temperature. And this thermoplasticized Gutta-percha for VAM compaction technique is used in alpha form, and in beta form, that is cold compaction. Gutta-percha points used with cold compaction are in beta form. Next one is the properties of Gutta-percha. The major properties includes biocompatibility, ductility, melting point, it is about 60 degrees Celsius, dimensional stability, that is expansion and shrinkage occurs due to heating and cooling, and ease of handling. It can be both used in alpha and beta for obturation depending upon the handling features. So this is the figure that is showing the Gutta-percha points. Next one is the current available forms of Gutta-percha. The Gutta-percha can be available in various forms like Gutta-percha points, auxiliary points, greater taper Gutta-percha points, Gutta-percha pellets, pre-coated core carrier Gutta-percha, in case of Gutta flow, syringe system, Gutta-percha sealers, and also medicated Gutta-percha like calcium hydroxide, iodoform or chlorhexidine containing Gutta-percha points. So these are the current available forms. Now we are moving to the advantages and disadvantages. Some of the advantages are, it is adaptation to the canal walls, that is compactability, dimensional stability, somewhat like said in case of properties. And the disadvantage is lack of rigidity, and it can be easily displaced by pressure, and it lack adhesive quality. Next one is root canal sealers. That's the classification includes according to Ingle, according to Cohen, and according to Grossman. So according to Ingle, it consists of cements, paste and plastics. According to Grossman, it includes, that is zinc oxide resin cement, calcium hydroxide cement, para-formaldehyde cements, and also paste. And according to Cohen, there is type 1 and type 2. In type 1 also there is 3 classes, and type 2 there is 4 classes. So you can read according to Cohen. Next one is ideal requirements of a root canal sealers. Some of the requirements are it is tacky when mixed, so as to provide good adhesion between it and canal bolts. It is able to create hermetic seal. It is radio opaque, so it is visible on the radiograph. So not shrink upon setting and non-staining to tooth structure, bacteriostatic, or at least do not encourage the bacterial growth, and it's set slowly because long working time allows placement and adjustment of root filling if necessary. So these are the ideal requirements, and some is also includes insoluble in tissue fluids, non-irritating, and it is soluble in common solvent, like that. Next one is resin based sealers. So some of the sealers are diacet, and its composition features and problems like its toxicity are all mentioned here, and AS26 H+, so also composition features and problems are mentioned. Next one is calcium hydroxide sealers like Seal Apex, and its compositions like base and catalyst. And next one is medicated sealers, silicone based sealers, glass ionomer sealers, all are mentioned here. Now we are moving to the monoblock concept. So literally meaning of monoblock, it is a single unit, and it means the creation of solid bonded continuous material from one dentine wall to the canal to the other. So it strengthens the root by approximately 20%, and the classification, it is based on number of interfaces that is present between core filling material and bonding substrate. The three types, that is primary, secondary and tertiary. In this primary case, this obturation is completely done with core material, that is use of hydrons, MTA, biogutta. And in case of secondary, there are two circumferential interference, that is one between the sealers and the primered dentine, and the other between the sealer and the core material. And the third one is tertiary. In that conventional gutta-percha surface, it is coated with resin, which is bonded with the sealer, which further bonds to the root canal bowl. So there is three circumferential interfaces are present in tertiary. So these are the three stages. So here you can see first figure shows the primary monoblock concept, second shows the secondary, and third one is tertiary monoblock concept. Now we are moving to the techniques. That first one is warm vertical compaction technique. So this method of filling the root canal, it was an objective of filling all the portals of exit with maximum amount of gutta-percha and minimum amount of sealer. So in this technique, the pressure, it is applied in vertical direction to heat soften gutta-percha, that causes it to flow and fill the canal space. So its basic requirements are continuous tapering, funnel shaped from orifice to apex, and the apical opening, it has to be small as possible to prevent the extrusion of the obturating material, and decreasing the cross-sectional diameter at every point apically and increasing at each point as canal is approached coronally. This one is the technique. So here in the figure you can see the technique, that is the first figure shows the selection of the plugger, that is according to shape and size of the canal. And the second figure shows the confirm the fit of the cones. The cone should be of appropriate size and shape. Sorry, this was the figure of warm compaction technique. So in the figure you can see first figure that shows the selection of the master gutta-percha cone, first figure, and the second figure there is a select the plugger, that is according to the canal shape and size. According to the canal shape and size, this plugger is selected. After that, there are two chances. If the larger sized plugger is used, it may bind with the canal and it may split the root. So in the figure C you can see the larger sized pluggers, and in case if they are using a smaller plugger, it may ineffective for the compaction. So in this figure you can see smaller plugger. And next figure shows the heated plugger that is used to compact the gutta-percha. And from figures F to H you can see backfilling of the canal. So preheated plugger is used to compact the gutta-percha so that it is compacted at the apex. Next we are moving to vertical compaction of gutta-percha, warm gutta-percha. In this case it causes dense obturation of the root canal, while lateral compaction provides length control and satisfactory ease and speed. And the advantages of both these techniques are provided by a newer device, that is Endodontic 2, which helps the operator to employ length control with warm gutta-percha technique. It comes with battery which provides energy to heat the attached plugger and spreader. And the technique used in case of vertical compaction is that master gutta-percha cone is adapted in canal, and the select plugger and activate the device. Insert this heated plugger in the canal beside master cone to be within 3 to 4 mm of the apex using light apical pressure. Afterwards, this unheated spreader can be placed in the canal to create more space for accessory cones, and this process is continued until the canal is filled. So in the figure you can see that procedure, vertical compaction. First figure shows the selection of the plugger according to the shape and size of the canal, and the figure B shows the confirmed fit of the cone. C, the filling of the canal by turning the system. D, compaction of gutta-percha by keeping the plugger for 10 seconds with sustained pressure. And the F, it is the removal of the plugger is seen here. And G, apical filling of the root canal is completed. So this is about the vertical compaction technique. Now we are moving to the lateral compaction technique. So it is the most common methods that is used for root canal obturation, and it involves the placement of tapered gutta-percha cones in canal and then compacting them under pressure against the canal walls using the spreader. So a canal should have a continuous tapered shape with the definite apical stop before it is ready to be filled by this method. So here you can see the technique, that is following the canal preparation, the master gutta-percha cone it is selected, which has the diameter same as that of the master apical file. And once we feel the tuck back with the master gutta-percha point, it is notched at the working distance and locks to the level of incisal and occlusal edge reference point. And the fit of the cone, it is radiographically checked, and if it is satisfactory, then remove the cone from the canal, and this sodium hypochlorite is placed there. And if the cone is too short to fit working length, then dentine chip debris, any ledge or curve in the canal, and treat them accordingly. If cone selector is going beyond the foramen, then either select the larger number cone or cut the cone to the working length. If cone shows S-shaped appearance in the radiograph, it means that the cone is too small for the canal. So in that case, a large cone can be selected in order to fit the canal length without binding in the canal should occur. So there is a chance for tooth fracture with excessive pressure. And now dry the canal with paper points, and then sealer is applied to the canal. After that, place the master gutta-percha into the canal, and coat the pre-measured cone with sealer and place into the canal. After the master cone placement, place spreader into the canal alongside the cone. Spreader helps in compaction of the gutta-percha, and it acts as a wedge to squeeze the gutta-percha laterally under vertical pressure, not by pushing it sideways, and it should reach 1 to 2 mm of the prepared root length. Next one is remove the spreader by rotating it back and forth motion, and this compacts the gutta-percha, and it will create a space for the accessory cones laterally to the master cone. And now place the accessory cones to this space and then repeat the above procedure until the spreader no longer penetrates beyond the cervical line. Now sever the protruding gutta-percha point at canal orifice with hot instruments. So this is the figure showing the lateral compaction technique. Next one is Mexpaden compaction or thermomechanical compaction of the gutta-percha. So this introduces a technique in which the heat is used to decrease the velocity of gutta-percha and thereby increasing the plasticity. So in this is fitted to a latch type handpiece and it is rotated at 8000 to 10,000 rpm alongside gutta-percha cones inside the canal walls. So at this speed the heat is produced by friction that may softens the gutta-percha and designs the blade forces the material apically. And the advantages and disadvantages are there. The advantages include it requires less chairside time and ease of selection and insertion of the gutta-percha. And disadvantages, liability in use in narrow and curved canals, frequent breakage of the compactor blades and shrinkage of the gutta-percha on cooling. And this all about the obturation of root canal. Now we are moving to next topic, that is endodontic emergency. And the long essay include, first one is define endodontic emergency, classify endodontic emergencies and mention briefly about the management of each one, add a note on trephination and the short note cracked tooth syndrome. The definition is pain and or swelling caused by inflammation or infection of the pulp and or periradicular tissues necessitating an emergency visit to the dentist for immediate treatment. And the classification of the endodontic emergency, that is includes pre-treatment, patients under treatment and also post-endodontic treatment. First one is pre-treatment, that includes dentine hypersensitivity, pain of pulpal origin, that includes reversible and irreversible pulpitis, acute apical periodontitis, acute periapical abscess, traumatic injury and cracked tooth syndrome. Next one is patient under treatment. It may include mid-treatment flare-up, exposure of the pulp, fracture of tooth, recently placed restoration, periodontal treatment. The post-endodontic treatment includes over-instrumentation, over-extended filling, under-filling, fracture of root and high restoration. Now we are moving to the management of endodontic emergencies, that is pre-treatment emergencies. So first one is dentin hypersensitivity. It is defined as a sharp, short pain that is arising from exposed dentine in response to stimuli, typically thermal, chemical, tactile or osmotic, and which cannot be ascribed to any other form of dental defect or pathology. So the two principal treatment options are plug the dentinal tubules that prevent the liquid fluid flow and desensitizing the nerve that makes it less responsive to stimulation. So these are the treatment. Next one is acute reversible pulpitis and its management includes removal of the cause, recontouring the recently placed restoration, removal of the restoration and placing sedative dressing, relieving the occlusion. Acute irreversible pulpitis management include the anesthesia is given. After that rubber dam is applied, access cavity is prepared, this pulp is removed from the pulp chamber and irrigation and debridement of the pulp chamber is done, determination of the working length is done, and after that the pulp is removed by cleaning and shaping the root canal, irrigation through the root canal, drying the root canal with the sterile absorbent points, and dry cotton pellet is placed with formocrosol or eugenol in the pulp chamber and it is sealed with the temporary restoration and relieve the occlusion. After that appropriate analgesic therapy or antibiotic is given if infection is present. Next one is acute apical periodontitis. In that case the management includes Anesthesia. After that, access cavity is prepared and the pulp is removed from the pulp chamber. Working length is determined. Cleaning and shaping, irrigation, same as that of the and this is the management of acute apical periodontitis. Next one is acute periapical abscess, and its management includes pulp debridement, incision and drainage. In case of any infection, the antibiotics are not localized infections, the antibiotics are not provided, but if there is any systemic features, then antibiotics are given. And the tooth is relieved from the occlusion in case of hyperocclusion, and in case of post-operative pain, NSAIDs are given. So this is a figure showing the incision and drainage. Next one is traumatic injury. The major objective of the treatment should be immediate relief of the pain. Since the pain is basically caused by inflammation, this and increased tissue pressure, the reduction of the irritants or pressure or removal of the inflamed pulp should be the main goal of treatment. And also there is reduction in tissue pressure in the pulp and pedoradicular tissues or removal of any inflamed pulp tissue that result in the pain relief or reduction. Next one is very important, that is cracked tooth syndrome. So it means incomplete fracture of the tooth with vital pulp. It is commonly seen to be associated with the teeth with large and complex restoration, and the treatment includes urgent care of the cracked tooth involves the immediate reduction of the occlusal contact by selective grinding of the tooth at the site of the crack, and the definitive treatment that aims to preserve the pulpal vitality by providing full occlusal coverage for cusp protection and full coverage crown if fracture involves the crown portion only, and if fracture involves the root canal, then endodontic treatment is done and restoration is done, and if the fracture extends the root, then extraction of the tooth is more preferred. Next one is intra-treatment emergencies, that is mid-treatment flare-up, and its prevention include psychological preparation of the patient, long-acting anesthetics such as bupivacaine should be preferred, complete cleaning and shaping of the root canal, analgesics is also prescribed. And the treatment reassure the patient, occlusion is adjusted, debridement, cleaning and shaping is done, analgesics and antibiotics are provided, and drainage, never leave the tooth open for drainage and recall the patient until the painful symptoms subside. Next one is exposure of the pulp. So it can result in severe sharp pain. In that case, complete removal of the pulp has to be done whether the pulp has damaged or not. Next one is fracture of the tooth. It can result in pain due to contamination of the root canal. So in that case, if fracture is vertical extending apical to alveolar crest, one should go for an extraction of the tooth, or in case of multi-rooted, should go for any hemisection or redissection. Next one is recently placed restoration. It can also present with pain with many factors like filling, micro leakage, inadequate pulp protection, galvanism due to dissimilar metal restoration or chemical irritations like that. And periodontal treatment, it can result in exposure of the lateral canals which can communicate with periodontal ligament space, and it may also causes pain. Hypochlorite accident, it may occur when the sodium hypochlorite that are extruded beyond the tooth apex that result in combination of symptoms like severe pain, swelling, profuse bleeding both through the tooth and the management include immediate aspiration and application of the ice pack, severe infection because of the tissue destruction that may should provide the antibiotics, analgesics or antihistamines, and in severe cases steroids and hospitalization is more preferred. And the prevention include use needles with closed end and lateral vents. The tip of the needle should be 1 to 2 mm short of the apex. Oscillate the needle in the canal. Do not force the irrigant into the canal. Tissue emphysema, its treatment include antibiotics, application of the moist heat, hospitalization and medical attention is provided. Prevention, air pressure while using the blast of the air should be directed at horizontal direction against the wall of the tooth and not periapically, and during any surgical procedure use low speed or high speed impact handpiece which do not direct air towards the tissues. Next one is post-obturation emergencies, that includes over-instrumentation, overextended obturation, persistent pain, vertical root fracture, high restoration, and the managements of the post-obturation emergencies. In most cases, it is very discomfort following the obturation that may last for 2 to 5 days. And to manage these emergencies, reassure the patients, analgesics are provided, occlusion is checked, and do not retreat randomly. Retreatment is done only in case of persistent untreatable problems. And these are the various analgesics that are used in endodontic emergencies, like aspirin, ibuprofen, paracetamol, NSAIDs, maximum effective dose ibuprofen 400 to 600 milligram. And in case of severe pain, this NSAID is combined with narcotics. Last one is trephination, and this is that when drainage through the canal is not possible due to restorative tissues, or in case of certain conditions like failing treatments or necessary correction of procedural accidents, surgical trephination can be used as a palliative measure. So it involves the surgical perforation of the alveolar cortical plate over the root end to release the accumulated exudates to release the pain. However, it is not the first line of treatment because of the additional trauma, invasiveness, and questionable beneficial result. And that all about the endodontic emergency. Now we are moving to the procedural accidents. And the short essay include: list the endodontic misshapes during cleaning and shaping, describe briefly the diagnosis and prevention of root canal blockage. And the procedural errors related to access opening is there, canal shaping and cleaning is there, with obturation is also there. In case of access opening, that includes treating the wrong tooth, incomplete removal of the caries, inability to locate extra canals, iatrogenic perforations, procedural errors in canal shaping, that is canal blockage, deviation from the normal anatomy, that is ledge formation, transportation, sweeping, separation of instruments, strip perforation. And the procedural errors with obturation include underfilling and also overfilling. Canal blockage, this blockage of the canal, it is usually because of inadvertent packing of the dentinal debris into the middle and apical third of the root canal during shaping procedure. So the major causes are filed compact apical debris, this fibrous blockage, and fractured instruments, restorative material, paper points or cotton. The corrections can be done by recapitulation, recurving and redirecting the instruments, recurving and redirecting the instruments. Still, if the block cannot be bypassed, endosonics can be used to dislodge the dental debris, and forcing any instrument may further compact the debris or may leads to perforations. Next one is prevention, that is always use a small sized instrument first, and sequential, this use of the instrument is in the sequential order, and always use pre-curve SS hand instrument, use reproducible reference points, use amount of the irrigants, and always work in a wet canal. Recapitulates repeatedly. If there is any loss of working length at this step, take the radiograph and confirm. Use smaller sized instruments to dislodge the debris, and again flush before the proceeding with the next phase of cleaning and shaping. And the prognosis, that is depends on the stage of instrumentation, disinfection and cleaning, and vitality of the pulp. This all about the chapter. Now we are moving to the surgical endodontics. Next topic, it includes this small long essay like explain apicoectomy and retrograde filling in endodontic surgery, enumerate the post-operative sequelae of endodontic surgery, and the short essays include classify retrograde filling material, add a note on MTA, enumerate the principles of endodontic surgical flap, describe any of the indications and contraindication, flap designs with figure, and detail about guidelines, indications and contraindications of endodontic surgery, different types of flap, Ausenbein Lubke flap, and mention the indications of periapical surgery. And last one is classify endodontic surgery, describe in detail about different flap design, and the short notes includes bicuspidization, hemisection and radisection, MTA and replantation. Now we are moving to the first topic, that is apicoectomy. It means surgical resection of the apex of the tooth, and indications include when the anatomy of the canal system has not been conducive to the non-surgical treatment, when root tip is resorbed or fractured, or when iatrogenic perforation or ledges prevents apical sealing. Somewhere like that, there are many indications you can treat. Next one is the steps. First one, this radiograph is taken in order to determine the level at which the root should be amputated. And next, cleaning of the area involved with antiseptic solution, administration of the LA, design the mucoperiosteal flap, that is tries to make an opening into the periapical region, extend the opening in the labial plate to obtain a good access. Bone removal is done for assess the root tip. Next, the root tip recession and curettage is done. Retro preparation and retrograde filling done to seal the root apex. Next one is debridement and suture the mucoperiosteal flap, and it is maintain firm pressure over the area of 10 minutes and follow up the case and obtain a post-operative radiograph to check the level of root amputation and future comparison. Next one is the classification. The classification includes surgical drainage, periradicular surgery, root resection, replacement surgery, implant surgery. Surgical drainage include incision and drainage, cortical trephination. Periradicular surgery includes curettage, biopsy, root end resection, root end preparation filling. Corrective surgery, which includes perforation repair, mechanical and resorptive, and root resection, hemisection, replacement surgery, implant surgery, that includes endodontic implant and root form osteo-integrated implants. Next one is classification of endodontic microsurgical cases, and it is classified into 6 types, that is class A, absence of periradicular lesion but persistent symptoms after non-surgical treatment. Class B, that is presence of small periapical lesion with no periodontal pockets. C, that is presence of large periapical lesion that is progressing coronally but no periodontal pocket. D, any of the class B or C with periodontal pocket. E, periapical lesion with endodontic and periodontal communication but no root fracture. F, that is tooth with periapical lesion and complete denuation of buccal plate. So these are the classification of endodontic microsurgical cases, class A, B, C, D, E and F. Next one is indication. Some of the indications are need for surgical drainage, failed non-surgical treatment, calcified metamorphosis of the pulp space, horizontal fractures of the root tip, procedural errors like instrument separation, ledging, root perforation, severe apical transportation, and anatomical variations like root dilaceration, apical root fenestration, like that. Indications: biopsy, corrective surgery, replacement surgery, implant surgery. And then the contraindications includes, many of them are there: periodontal health of the tooth, patient's health conditions like cannot be given in case of leukemia, neutropenia, uncontrolled diabetes mellitus, very old patients, uncontrolled hypertension, bleeding disorders, immunocompromised patients, Patient's mental and psychological status that does not deserve any surgery, and patient that is unable to handle stress for long complicated procedures. These are some of the contraindications. Next, we are moving to retrograde filling, that is filling placed in the apical third of the tooth root to seal that affected part of root after surgical intervention. And the classification includes metals, cements and sealers and others. Metals, that is gold foils, silver post, titanium screw amalgam. And the cements and sealers, zinc oxide eugenol, polycarboxylate, GIC, MTA, and others includes composite resin and gutta-percha. And these are the principles and guidelines for flap designs. That is it. First one is avoid horizontal and severely angled vertical incisions because gingival blood supply occurs from supraperiosteal vessels and these follow vertical course parallel to the long axis of the teeth. Collagen fibers of gingiva and alveolar mucosa form attachments for crustal bones and supracrustal cements to the gingiva and periosteum. Base of the flap should be more than free gingiva to preserve an adequate blood supply. Avoid incision over radicular eminence. Incision should be placed such that the flap is repositioned over the solid bone. So you should read the principles and guidelines that is given here. So very important. Next one is flap design. The classification include full mucoperiosteal flap and also limited mucoperiosteal flap. In case of full mucoperiosteal flap, it includes triangular, rectangular, trapezoidal and horizontal, and limited, that is subgingival and submarginal curved, submarginal scalloped, rectangular. And these are about the full mucoperiosteal flap: triangular flap, rectangular flap, trapezoidal flap, envelope, semilunar. Next, 3-mark question, that is ocean bean loop cave flap or submarginal scalloped rectangular flap. So it was developed by an endodontist and a periodontist. It is a modification of a rectangular flap. So in the figure you can see, in this scalloped horizontal incision it is given in the attached gingiva which forms 2 vertical incision that is made on each side of the surgical site, horizontal and 2 vertical. There is indication is given in case of gingivitis or periodontitis, and advantages that includes the marginal and internal gingiva are not involved, crustal bone is not exposed if there is adequate surgical access, and good wound healing. Disadvantage is also there is flap shrinkage, difficult flap reapproximation and wound closure, limited apical orientation, and limited or no use of mandibular surgery. Next one is mineral trioxide aggregate or MTA. Its composition include tricalcium silicate, tricalcium aluminate, tricalcium oxide, silicate oxide, bismuth oxide, that is added for radiopacity, and the properties, that is setting time is 2 hours 45 minutes, compressive strength, that is 40 MPa, insufficient weight loss following setting, and these are the advantages and disadvantages. The MTA placement technique include preparation of the root end is completed. Bony crypt, it is packed with the sterile cotton pellets, MTA powder and liquid, they are mixed and to put the consistency, and this mix it is carried to site with the help of an amalgam carriers and is placed into the preparation, and this MTA it is compacted with micropluggers and cleaning the surface is done with cotton pellet. Next one is replantation. So this intentional replantation is defined as the act of deliberately removing a tooth and following examination, diagnosis and endodontic manipulation and repair, returning the tooth to its original socket. And the classification include intentional reimplantation and uni-intentional reimplantation. And these are some of the indications. Contraindications like curved or flayed canals, non-restorable tooth, moderate to severe periodontal disease, missing interseptal bone, presence of vertical root fracture. And some of the precautions that should be taken are this root surface, it should be kept moist. Out of the socket, the time should be of shortest possible. One should take care not to damage the pedial cells and cementum. And next one is the technique. Now we are moving to the hemisection or root section or root amputation. So it is defined as removal of any unrestorable root which may be affected by the periodontal structural and caries, cracks or caries. And hemisection, it is independent of bicuspidization. It includes splitting of the tooth, extraction of one half, that is followed by bridge, whereas bicuspidization, it involves retaining of both the split section of the tooth and then it is restoring with crown. Indication, that is severely curved canals or extensive calcification, fracture of the root, resorption, caries or perforation involving one root. And the contraindications include fused root, uncooperative patients, endodontically incompatible remaining roots. And the technique: before the root resection, carry out endodontic treatment in root to be retained. After this, carry out root resection. It is basically two approaches, that is vertical and horizontal. In vertical, here complete root is resected along with its associated portion of the crown, and this procedure is also called as hemisection or trisection. It is mainly done from mesial to distal in maxillary molars and buccal to lingual in case of mandibular molars. And horizontal, in this the root is resected at the point where it is joined to the crown. It is also called as root resection. So this is the figure showing. Next one is bicuspidization. It is defined as the surgical separation of multi-rooted tooth into two halves, then restoring each root with the separate crown. So it is commonly carried out in mandibular molars where the mesial and distal root, they are separated by the respective crown portions. And the indications, it mainly used when the periodontal disease involves the furcation area, and contraindications like fused root and cooperative patients, it's not used. So this is the bicuspidization figure. And that all about the surgical endodontics. Now we are moving to endodontic periodontal relationship, and it's a very important chapter. Only one question, that is classify endo-perio lesion, describe briefly about the management and the pathway of communication between pulp and periodontium. First one is the classification according to Simon et al. This is most commonly employed one. Based on the etiology, diagnosis, prognosis and treatment, it is classified into 5 groups. That is primary endodontic lesion, primary endodontic with secondary periodontal lesion, primary periodontal lesion, primary periodontal lesion with secondary endodontic involvement, and true combined lesions. And next, that is type of the lesion and treatment. Now we are moving to the each type. That is, first one is primary endodontic lesion, and its treatment involves conventional root canal therapy. So no root planning or planing can be done when the sinus tract is along the periodontal ligament, because these fibers, they are important for reattachment to occur. Next one is primary endodontic with the secondary periodontal lesion. So here first endodontic therapy is done, that is including the root canal treatment. After that periodontal therapy is done. And third one is primary periodontal lesion. Here this periodontal therapy to eliminate the pocket is indicated. After that root canal therapy, it is not usually indicated unless the pulp vitality test results change, and periodic re-evaluation is necessary in case of primary periodontal lesion. Primary periodontal lesion with the secondary endodontic involvement, the treatment includes both endodontic as well as the periodontal therapy. And the last one is true combined lesion, that it also includes both endodontic and periodontal therapy, including root recession, and also hemisection is proposed. So these are about the type of the lesion, endo-perio lesion and its treatment. Now we are moving to the pathway of communication between pulp and periodontium. So this is the flow chart that is showing the pathway of communication. So the infection can occur from both the pulp as well as the periodontium. So in the flow chart you can see a healthy pulp that is turned into infected pulp, and from there the healthy periodontium is turned into diseased periodontium. And this flow chart, it is surrounding, that is both the pulp as well as the periodontium is infected. This bacteria transfer occurs from both pulp and also from the periodontium. So this is the pathway of communication between the pulp and periodontium, and this is how the endo-perio lesions occurs. And this ends the endodontic periodontal relationship. So here ends the few topics of conservative dentistry question paper. Hope you all understood this section. We will come back with another section. Thank you all.